presenting on behalf of Medicine One in dire straits. Starting with the case scenario, Mr. S, 24-year-old gentleman from Sivagangai, presented with fever for 5 days, vomiting for 3 days, and red-colored urine for 2 days. So he was apparently well till 4 days back, and then he developed fever, which was high grade associated with chills, which was intermittent, relieved with taking tablets. He also complained of nausea and had 5 to 6 episodes of vomiting for 3 days, which was non-violent bloodstain immediately after drinking water and after eating food. For the past 2 days, he noticed that his urine was red colored. Past history, he had similar complaints in 2019. Family history wise, his younger brother, who is currently 10 years old, has been diagnosed with G6PD deficiency 5 years ago. So on examination, his BP was 120/70 millimeter of mercury with a heart rate of 90 per minute, saturation of 98 with a respiratory rate of 18. On general examination, he was dehydrated. Pallor was present and icterus was present. Systemic examination, abdomen, it was soft, non-tender. He did not have any hepatosplenomegaly. Other system examination was also normal. So this is the urine he gave to us at the time of admission. So it's full cola colored, black colored. So our diagnosis at the time of admission was UT in view of hematuria, intravascular hemolysis in view of family history, as well as he had pallor, he had jaundice and black colored urine. Malaria, dengue also is another possibility, and drug-induced hemolysis due to this G6PD deficiency. So coming to the investigation, his hemoglobin at the time of presentation was 7.8. His smear showed anisopoikilocytosis, otherwise did not have anything. Total count was 5,500. Neutrophil of 73, lymphocyte of 20. Retics at the time of presentation was 2.64. Creat was 1.32. LFT showed a total bilirubin of 2.2 and direct bilirubin of 0.28. So indirect hyperbilirubinemia suggestive of hemolysis. LDH was also 2,393. His malarial smears were initially negative, and dengue serology has come as positive for IgG, IgM, and NS1. So this is the urine analysis we had present at the time of admission. So here we can see that in the blood test, it is actually showing 3+, which is dipstick part positive, but on microscope, it's only showing RBC of 1 to 10. So this is suggests that patient is having hemoglobinuria and not hematuria. So hemoglobinuria actually suggests that the patient is having intravascular hemolysis. So our differential, so our urine hemoglobin is also positive on evaluation. So from our side, malaria was negative, DCT was negative, cystocytes were also nil. So because younger brother had G6PD deficiency, we thought patient is also likely having this G6PD deficiency because he's been having infection. There could be a trigger for this hemolysis in this condition. So as for the differentials, initial malaria, that is ruled off blood culture. Second, that also 2 cultures were negative. So IAHA and MAHA, we ruled out PCT was negative and cystocytes were nil. So PNH, PCH, he did not have any early morning hematuria or any red colored urine or anything. So with the background history of G6PD deficiency in the family, so G6PD hemolysis was one thing we thought of. So during the course in the ward for our patient, so initially at the time of presentation, his hemoglobin was 7.8. As the day progressed, his hemoglobin was dropping. That means active hemolysis, intravascular hemolysis was going on. After 2 to 3 days, his hemolysis stopped. After that, hemoglobin picked up. This can be correlated well with the temperature chart. We can see that the initial 2 to 3 days, actually patient had a fever spike. Once the fever spike has actually settled, the hemolysis also settled and hemoglobin actually picked up. So this is the urine color as well as the creatinine value which we observed during his course. So initially it was cola colored. After the next day it became like this. So in 2 to 3 days time, it actually became clear. But we also noticed that because of the severe intravascular hemolysis, the patient is prone to develop pigment-induced nephropathy due to hemoglobin. So which we can see in this graph. So initial value was 1.35. As the days go by, it is progressively increasing. By day 12, 11, 12, and 13, we notice that it is almost reached more than 6. So, so our patient, how he was managed in the ward is to prevent the hemoglobin from dropping to less than 7. We had to transfuse multiple units. Totally, we transfused 5 units of packed red cell, and we also had adequate IV hydration with strict IV charting. And we also gave forced alkaline diuresis to prevent pigment nephropathy with the target urine pH of more than 6.5. So finally, the patient, he did not develop polyuria, fluid overload, and did not require dialysis as well. So our final diagnosis, his presentation was dengue fever with warning signs, which has actually triggered a Coombs negative intravascular hemolysis, probably due to G6PD deficiency with the background family history. And he also developed pigment-induced acute kidney injury. So coming to the G6PD deficiency per se, so inheritance, this is a X-linked recessive pattern of inheritance. Usually, females are usually carriers and males will be affected in view of the X-link. But here we can see that in our family, in our patient's family, both of them are actually affected, which is very unusual. So we also think that in addition to this common recessive pattern, there might be another mutation or another variant which could actually predispose all the family members, mainly the boys, to have this hemolysis, both of them being having this G6PD deficiency. So now coming to the proportion of infection related G6PD induced hemolysis, this is a study done in 2007 to 2012 where they've looked at the cause for the hemolysis in the patient. So in total of 196 patients, we can see that most of them is actually related to food and infection. So infection per se alone can cause only 4.6%, which is actually seen in our patient because he did not have any drug intake from outside hospital and he did not take any fever beans or anything. So this is also one case report where they've looked at the dengue fever as a predisposing factor for this hemolysis in the G6PD deficient patients. So where they have this 45-year-old gentleman who had similar presentation like our patient, fever for 5 days. 3 days into the illness, he developed yellowish discoloration of eyes with vomiting. On evaluation, he had Coombs negative hemolytic anemia as well as G6PD deficiency. For him also, they've treated him with hydration and multiple transfusion. So now coming to the course of the acute hemolysis, this is a study where they've looked at the bilirubin level, have hemoglobin level as well as the macroscopic hemoglobinuria. Here we can see that in the lower down, after 4 days, almost the hemoglobinuria actually cleared, which is also the same with the patient. So 5 days into the illness, his urine actually cleared. And his hemoglobin also, after almost 5 days, it actually picked up. So, which is in actually same as in our patient. So, how to diagnose G6PD in crisis? It's not possible to confirm during crisis if we had not known the diagnosis prior. So we just assume that the patient is having this probable diagnosis because of the family history after we ruled out other non-immune mediated intravascular hemolysis causes. So it has to be confirmed after 1 month or genetic testing as well. So how to manage two things, hemolysis AK, this is already mentioned. So only this alone I'll explain. Pigment-induced nephropathy, this is study done in MMC where they looked at 46 patients who had this biopsy confirmed pigment-induced nephropathy. So they mentioned that most of them had rhabdomyolysis and hemolysis. So almost every patient required, only 12 patients went into chronic kidney disease, but they have not mentioned whether they had any predisposing conditions or so. So challenges in our patient was the patient had continuing hemolysis and hemoglobinuria. We had to balance transfusion as well as hydration, and then we have to maintain forced alkaline diuresis. So only after fever settled, hemolysis stopped. So AK continued to evolve even after hemolysis. So that we have to manage strictly and monitoring, and then we had to find out. So the learning points. So.
Thank you. The questions for Brightlin will be during the coffee break. Anyway, well done. I think we had 6 fantastic presentations. Maybe 6 is a bit tight, but I think it's fantastic learning value. Let's give all the presenters a good hand. So I have the unenviable task of giving a winner. So Nishit Nanda, well done. Okay, guys, thank you. We'll meet next.